You're going to learn how to tape, and you're going to all practice, and you have to do it with gloves on, because that's what you're going to have on. So you need 2 tongue depressors, popsicle sticks, whatever you want to call them. They're in packages in there. So that really you should be gathering while you're gathering everything. And you can have this done ahead of time if you want to have it ready. So what you're going to do is take one end, go like this, with a little tab open up here, and tear it, just like that. Tear it, you can. And then put with, the little dog ears. So that later on, because that's going to be one of the ends, and so later on, it makes it it's very easy, because this is going to have to be redone. Because we have to move tubes, which we'll talk about. And then go over like that. So it's down like that. I know that's not perfect, but you get my point. Like that. And then you're going to go, so you have to estimate that we're going to be going around. This will be underneath, and we need enough tape left over, remembering that this is also going to be extended now up when we get there, which I'll show you. So you'll have to practice a couple times, you guys, so you can eyeball, because you really want to be careful you don't get way too much tape. So then tear off the other end and put the other popsicle stick at this end. And you do the same thing over here to tear over your, put your little flaps down. Sticks to you. And then go like that. And then this area that's left, you're going to cover with tape. And if you need to, you can lift up a little bit on the end, because that tape needs to be underneath the popsicle sticks. Hold on, this is not. It all wants to stick to each other. So the idea here is, you guys, in the middle, this is tape on both sides, because that is going to go back behind your patient's neck where his hair or her hair is. So the idea is it won't stick. It's going to go underneath. And you're going to take one end and take the popsicle stick and pull it off. So now you have exposed tape, okay? And then pull off the other end. Keep your pilot balloon out of the way. And then tear it the rest of the way. And so what's going to happen is one end is going to go like that. It's probably not the best tape job I've ever done. I haven't done it for 5 months. People do this all the time. So anyways, I think from this tape is weird.
Can we just rip it? Why would you use this?
Huh?
Slide it under their head. It makes it easier.
Yeah.
A lot to do in a high stress situation.
Well, if you don't have a tube holder, you have to do it. And when you do it every single day, it's different.
Yeah, because I see them doing my work and they did like it was nothing.
Yeah. It's a,
You guys don't have two holders
Yeah.
there?
What?
They
Take
use that?
it.
Popsicle sticks and everything.
No, she was just like rip, pull, pull. It was like it was nothing. She did it all the time.
Yeah, it used to be able to stay on the
okay, trust me, you guys, you're not going to be able to just rip it and tape it the first time. I haven't done it for 5 months, and I've been an RT for 22 years. So,
That's what I'm saying. They do it all the time. So it's
yeah,
very
when you
natural.
do it all the time, you will get your routine down to it. I'm just teaching you a way so you learn how to do it and can do it effectively right now, okay? What you'll find is that if you're not used to doing it and you don't use these, tape gets everywhere, it gets stuck to the patient's hair, it's stuck to the head, I want it over here, so this at least keeps things together while you get your rhythm together. When you go practice somewhere, and if you work at a place that has to tape all the time, you'll get your rhythm down. So we wrapped it around one side, and now we're going to take the popsicle stick off of this side, tear down again, something, this is not the right tape either. We have better tape in there. And then you're gonna wrap it around the other way. So that it holds your tube in place. Your little dog ears that we covered at the end up here, so that when you need to retape and replace this, you can just pull it very easily. Then you want to take one piece of tape, huh?
Always on the top lip.
Yes. One piece of tape and cover over it because it makes it look pretty. And that sounds stupid. This is the Mr. Rutherford method, and it's actually a great way to do it. Nurses love it, families love it. You have to remember that this is a person here. I know we have Mr. Plastic Man here, but in the real world, this is a person here, and what better to have a family think that you took the time to make it look nice than otherwise, where you'll see how it looks when you don't have that other piece over it, and it gets all in their face, it's dropping down, and it's all over, and it's yucky.
What if they had a
So-
big mustache?
Huh?
What if they had a big mustache?
That can be a pain, and you might have to put it on the bottom in that case. And then what you can do is on the top here, you guys write the date and the time that you changed it. Because this is going to have to be done like every 12 hours.
On your face real quick.
So because you have to move this from place to place at a minimum of every 12 hours. Usually a lot of places will do it every 8 hours if they're taping. Places that use the Hollister, yes. Oh, no. You're literally untaping it. You're leaving it at wherever it was at the teeth, which is the one thing I forgot to tell you guys. Make sure when you intubate, you get the tube in, you yell out to the room, it's at 22 at the teeth, or wherever it is. Clinically, you're gonna see a lot of different things. You're gonna see people use gum lines and all of that. I mean, lip lines, but everybody's lips are different. They can swell. Are we going on the front of the lip, the top of the lip, the middle of the lip? The teeth and the gum line doesn't change. So for our purposes, and if you get a choice, I want you to use the teeth or gum line. It's much more accurate. So 22 at the teeth, so you know where it is, and that's going to get recorded. And when we do our x-ray, that's where it should be. If we need to move it, it was done at 22 at the teeth. That's where we need to make sure we're at. And then when you move your tube, you need to make sure when you move it, it stays at 22 at the teeth. So when we move it, we're literally just taking it and sliding it over. And you need to tell your patient because it might be a little bit uncomfortable for them. So if you're using the Hollister, this has these sticky patches on them that stick to somebody's cheeks like that. And it's not fun coming off. So that's one downfall to these that I don't like.
Miss Foss, what if they have like a beard and a lot of facial hair?
Depending, it might have to be shaved. You have to be able to secure your tube. So it depends on how extensive it is and if you can work with it or not.
Yeah, I've seen them shave their face.
Yeah, sometimes you have to. So if they have a lot, then it might be you could just shave this area just enough to be able to tape it down, but. Sorry, Happy.
You have little patches. Happy patches.
Happy patches. She said it. Mommy. So if you guys use this one, this is nice because it's meant to, so if this was on our patient, then what you do is, oh, it's upside down, sorry. Take this, and then this wraps around the tube. It has a little tape on there. It wraps around the tube and then goes in here and snaps down. And then this has what reminds me of a little zip tie. You have these little tabs that push in, and then you can move it. So they move their tubes like every 2 hours, people that have these. So they'll do left, middle, right, middle, left, every 2 hours. That's excessive. It doesn't have to be done that often. So minimum is every 8 to 12 hours. Usually once a shift is the practice, that's what's going to be done for.
Why are they doing that?
It's because they'll have their lip. It's
Move the tube to prevent pressure sores.
Yeah, so they get sores on their lips.
Yeah, they'll get sores from it. Okay, questions about any of that?
When you're taping.
Sorry, go ahead.
Those sticky pads, do you have to warm them in your hand?
Yeah, you do ideally. You can take them and just warm them for a second, and then you can put them on there.
When you tape it, do you still go left, middle, right, middle, left, or do you go one end to the other?
Generally, most places go one end to the other, but it will depend on where you work, on what they do. So there are places that strictly use tape, you guys, they don't use any of these, so that's why we teach you how to tape. And again, once you get a method down and you can do it, I don't care how you do it as long as it's done right. Let's see. Okay, so let's say for purposes of this, our patient is all good, and we're gonna put him on the vent. So we're gonna put our Ballard on. And now he's on the vent. Voila. So for those of you, one thing I want to point out, for those of you who are not right-handed, still have to intubate like you are. I talked to at least one of you, right, Jeannie? So the reason is, when you put this in, if you are left-handed and you want to intubate with your dominant hand, you are putting your blade in like this. The tube has to be here. You can't get it. That's the only way the tube can go in, is to go through this channel. So it's why you have to have it in the patient's mouth with your left-handed, so you can slide the tube in along that line. That's why you have to intubate with your right hand. So you must always use your right hand to put the tube in, the left hand for the laryngoscope and the blade. And it's because of the design of the blade. We're not discriminating against left-handed. My kids are left-handed, so it's just the way the blade was made. I guess it was made by a right-handed person.
Yeah.
Okay, yeah. So I put out a Lupin's trap here just to let you guys know that almost every hospital will get a sputum sample as soon as the patient is put on a vent. Why? Checking for pneumonia, because they don't want to be held responsible for ventilator-acquired pneumonia for a patient who had pneumonia when he went on the vent. So they send for a sputum sample. It's clear your patient gets pneumonia. We gave it to him. That's how it works. So you're almost always going to get a sputum sample nowadays. While we got our patients intubated, what drugs can go down our ET tube?
Naval.
Narcan, Epi, Atropine, Versed, I already had out. What's the other one? Lidocaine, don't forget. Oh, just in case, McGill forceps, you won't hardly ever use these, and I don't even know that you'll ever see them on a test, but these are used if someone is nasally intubated. They use this so the tube goes in through the nose, but then you still have to visualize to see the tube go in. They have to use these to pull the tube down. So these go into the back of the throat. I know, it's yuck. So if you hear the word McGill forceps, that's what they're talking about. Kind of yuck. Okay, so McGill.
If they don't need to be on the vent, is that the TVs?
Oh, not exactly. That's a good point. Let me show you. So let's, for a second, before I go into cuff pressures, let's say our patient doesn't need to be on a vent. I thought I brought Stephen over here.
Just protecting the airway.
Huh?
Just protecting the airway.
Yeah, we're just protecting the airway. I mean, we have our mist and whatever weight, our T piece, remember it's just a T, and it will have a long piece of corrugated tubing. I thought I brought one out, but we talked about this last term, right? How to set this up. Long piece of corrugated tubing to your bottle.
Mm-hmm.
Then the T piece will go onto the ET tube like that. You have a little reservoir that you'll see mist coming out, so you have a patient that they can draw from that little reservoir. So imagine corrugated tubing there, I'm sure you can. We know what it looks like. To the wall. It's actually a very simple setup. Oh, so his water is in front of the camera.
Oh.
Are you trying to set him up?
What?
Anyways, so this would be at the wall, dialed in at whatever FiO2 to the T piece. So if you see, put a patient on a T piece adapter. Also remember this word, you guys, write it down because it's notorious for being on your boards. It's Briggs. Briggs adapter, B-R-I-G-G-S. It's just a fancy word for T-piece. So it'll say humidified aerosol by Briggs adapter, and you're going to be like, what the hell is that?
Can you take a picture of
It's a
notes afterwards?
T-piece. What are you doing?
I wrote it down in the
Picture. Oh! And Briggs is the name of the person who has made millions ends on this little piece of plastic. It's who invented the T-piece, is Mr. Brigg. So that's why they call it a Briggs adapter. But it's nothing more than a T-piece. So that's how you would do that for someone who just needs an airway. Otherwise, we're gonna have our Ballard and our patient is on our vent. Pretend, or we're hooked up to our vent. So now we're gonna talk about cuff pressure. So you know when we intubated, we just put air in. We're trying to get our patient's airway protected, get him ventilating, oxygenating. It's an emergency situation. But now he's on the vent and we need to maintain proper cuff pressure. Why is this important?
So you don't damage the airway.
So seal, good point, and also we don't want to cause damage over time. Your cuff can be overinflated, it can be underinflated. The proper thing is to have proper inflation. So we don't need too much, we don't need too little. Too much is going to cause trauma on your patient's trachea. Too many people I see do this. Oh yeah, it feels good. Oh yeah. Okay? I am not kidding you guys, you're going to see it. RTs go in and go, yep, it's good. All right, I'm glad that's not your lungs that stuff is in. That is not the proper way. And I'm telling you, if you haven't seen it, I've seen bronchs and pictures of damage from cuff pressures being too high, and it is not nice. It erodes into the airway, it causes sores, it can cause ulcers. That's not fun for your patient. And eventually, if it was done long enough, it could cause a fistula, which we don't need to do. So there's 3 ways you need to know about that you can monitor cuff pressure, and how you do it will depend on where you go. But first and foremost is our cuff meter, cufflator, whatever you want to call it. It's nothing fancy. But all you're doing is taking this and putting it onto here. And then it will show you a readout. And you'll see, and I'll make sure I bring these around too to you guys when you're at your stations, because we only have a couple of them. But you'll see when you insert it in here, it will go to a certain area. There's green, kind of in the middle, and then there's red, danger. Obviously we don't want it in the red. There's a perfect green that's on there. The perfect green is between 20 and 30. Seriously? What are you doing over there? Okay, but not right now, because this is more important.
What about babies? Same patient?
Doesn't have cuffs.
I don't, yeah, they
They're
don't,
uncuffed.
neonates don't have cuffs. Sometimes
No.
peds do. I'll show you trachs and some baby airways next week. They're so tiny. Some pediatric tubes have cuffs though. So, I personally don't like this method, and I'm going to tell you why, and the board is going to try to trick you with questions about it too. So, but just so you guys know, the way this works, when you have your pilot balloon in there, you squeeze it to add air, and then use the red button to take away air. Okay? You have to be careful with these two, because a lot of times just by putting it in there, it takes air out. So you have to be real careful using them. So just pay attention and make sure that it's where it needs to be, but you squeeze it, and you'll see, when you squeeze it, you'll be able to see it adds air in and changes your cuff pressure. But for purposes of telling you how to use it and how it works, so between 20 and 30 is good. The reason I don't like this is, doesn't everybody in this room have a different airway?
Mm-hmm.
Would it be unreasonable to think that everybody needs a cuff pressure between 20 and 30? Yes, that's why I don't like it. But it's used and it is technically correct. So the other two methods are much more superior. So we have what's called the minimal leak technique and minimal occluding volume, which I'm going to go through both. The minimal leak technique is commonly abbreviated MLT, so you'll see MLT, it was checked by MLT. And what you do for that is you'll take your stethoscope and you'll listen. Oh, by the way, you guys all need to have your stethoscopes here next week, because we're going to be doing intubation, extubation. You can't intubate without, you shouldn't extubate without your stethoscope. So make sure you have those. You're also going to practice how to put these on with one hand. Very common. You need to be bagging. Stethoscopes around your neck. You'll be able to put it in your ears with one hand so you can listen. So you'll practice that too. I had a student once, she's like, we intubated this patient and we were bagging and nobody was listening to the breath sounds. And I didn't know what to do because I couldn't get my stethoscope on. She's like, I was trying. That was funny. Okay, minimal leak technique. What you're gonna do is listen over the trachea. Pull air all the way out. So your cuff is deflated. Then put air in until you don't hear a leak anymore. So let's say you need to pay attention. So you pulled out 5.5 cc's of air. And then you put in 3 more. When you put it back in, and at 3 cc's you heard the leak stop, then that tells you this patient really only needs 3 cc's. You see what I'm saying? So, but what's important is once you hear the leak stop, you pull back on your syringe just a very tiny bit until you hear a very small leak. Very minimal, that's where it gets its name, minimal leak technique. So, and you guys, if you haven't listened over a trachea when the cuff is deflated, you're going to hear it. It's a bunch of rumbling noise because you're hearing the air leaking out from all over the place. So to go through that again, you're listening over the trachea. Withdraw all the air out of the cuff. So you hear a large leak, and you'll hear it. Insert air again until the leak stops. And then pull back just a tiny bit so you have a very small leak. That gives you the minimum amount of pressure required in your cuff and on your trachea to not have a leak in your circuit and in your airway.
So then how would you measure the pressure?
You don't.
Oh,
It's done by volume, however many cc's you put in. It doesn't matter. What matters is that we hear a small leak. That lets us know that there's some little tiny bit of air movement around the cuff and you're not putting too much pressure on your trachea wall. If it's completely occluded or maybe a 30, how do I know? I might be completely occluding and putting pressure on my tracheal wall. So it's not so much the pressure that matters. What matters is that we're using the least amount of air possible.
How can I hear you?
So when you listen with your stethoscope, and what you should do when you start clinic is ask your preceptors to let you do it. But so you'll put your stethoscope over it, pull air out, and you hear this really loud rumbling sound. I don't know how else to describe it. And then you put the air back in and it totally stops. And then you pull it out to it's like a small whistle type, just a little tiny bit of air.
Where is it? Okay.
Yeah, you're listening right here. Yep. So the best thing to do, you guys, is ask your preceptors to let you do it. Or you really don't even, as long as you're comfortable with doing it, you could just do it. Just make sure you put the right amount of air back in. Most preceptors will let you do it so that you practice it on a real person. So that is the absolute best technique. So there's always questions on the boards too about this. So it will tell you cuff pressures, and you guys think the cuff pressure is good. So you don't want to do anything. But the correct answer is to do a minimal leak technique, because for the very reasons why I told you, just because it's 20 doesn't mean it's right. We want to do a minimal leak technique to find out the exact amount of air that we need in it. And I'll give you some examples of some questions so you'll see what I mean. So the only difference between that and the MOV, which is the minimal occluding volume, is that you take the air out and you put it in until you don't hear a leak, and that's it, you're done. It just doesn't go that additional step. That's the only difference. So that's the MOV. You laughed, but you wouldn't believe how many preceptors do it like this. Oh yeah, there's air in the cup. We're good. Occluding volume. Huh? That minimal occluding volume? MOV.
We have to check the pressure.
Check, for me personally, I would check cuff pressure at the beginning and the end of my shift. When I first come on to make sure where I want it to be, and at the end of my shift before I leave, and then anytime you think there might be a problem, you walk in the room, you hear it leaking, it got repositioned or something like that. Otherwise, the beginning and the end is fine. You know, it's good where you want it when you come in and good where you want it when you leave.
Do you do extubation palpation.
Every time you come in and do a vent check. That's done every time.
Every 4 hours.
Most good places do vent checks every 2 hours. So you'd be doing that every 2 hours. Because you need to do breath sounds to assess for suctioning. We never just suction. We only suction if there's a need for it. All right, any questions on any of this? No? All right, who wants to practice? Okay, Annie, Gina, come up and let's see you do one.